Okay, thanks, Philip. It's my pleasure now to introduce Dr. Cliff Mann. Cliff has been a full-time emergency medicine consultant in Taunton, Somerset for 17 years. He trained in the UK as well as New Zealand and Australia. His previous roles include Training Programme Director and Head of Postgraduate School of Emergency Medicine. He was elected President of the Royal College for Emergency Medicine in 2013, and his role as President is focused on describing the challenges to emergency medicine and articulating the solutions. If he wasn't a doctor, Cliff would be a mathematician, but he has said that his worst mistake of his career was thinking that A&E would give him a better work-life balance than general practice. Thank you, Cliff.
Thank you very much. Only some of that was submitted by me. It's a real privilege to be invited to speak at Dublin Castle, and I'm really very touched that you've invited me over the water to speak, and particularly I think in 2016, which is clearly a very historic year, 100 years after the 1916 uprising. So I'm really very grateful for this opportunity to be here today. I put this slide up really because it's got my cartoon on, and I'm very proud of this cartoon because it shows I got into the BMJ with a picture without actually having to die first. And it's one of my major publications, frankly. So I was asked to talk about the 10 priorities for sorting out the emergency medicine crisis. I've got a number of slides, but I will try and pick up the themes that I think resonate with what I've heard has been going on before this afternoon. So the first of that is this word crisis. And you'll see that actually that doesn't feature on this slide at the moment, but it did feature in the college's lexicon for some time. And it was a useful word, but I think it's a time-limited word. So it started off very usefully because it got people to take some notice of what was going on. And we decided we would host a crisis conference at the college, one of the few good ideas I've ever had. It wasn't an overwhelming success. We had 5 people there. We had myself, Ruth Brand, the then registrar. We had somebody from the BMA, somebody from the GMC, and somebody from the MDU. But for some reason, the HSJ, which is a journal, is a health services journal, which is published weekly and has a large online presence as well, and goes out to all health services managers, got wind of this crisis conference and phoned me up about it. And they asked me what we were discussing, and I told them in some depth what we were discussing. I just failed to mention that there were only 4 of us plus me discussing it. It therefore got a bit of traction, actually, and people did start to take some notice of it. The problem with it is that after a while, the word crisis seems to be sort of self-fulfilling, and everybody imagines that you're in meltdown. It encourages a victim mentality, and that does nothing to raise morale. And so we stopped officially using the word crisis as a college at Christmas of 2013. Christmas of 2013, just going into the winter of 2013, 2014. That's not because all the problems had been solved, but it was starting, certainly in the UK media, to be used as a tool simply to hit politicians and to some extent hospital trusts and managers. And actually, whilst I'm no great fan of all the people who are politicians and hospital managers, actually they are the people we need to be working with if we're actually going to sort this problem out. So sooner or later, you've got to give them a bit of a break. And the break is predicated on the fact that we'll stop throwing stones if you start listening to our suggestions. And that was the deal we basically brokered. So we started off with this first document on the left, which was the Chem 10. I'm now pleased to hear that the Irish Association of Emergency Medicine are producing a similar 10 priorities. And as I said at lunchtime, if it's a really good idea, and I think this resonates with what people have said, if it's a really good idea, you can use it more than once, and more than one person can use it. And clearly, all the stuff about improving methodology is exactly predicated on that. Of the 10 key items, we broke it down into 5 of the things that we needed to be doing, which are the things on the left. You don't need to be able to read them. And the things on the right was what we needed other people to do. And again, we wanted right at the outset to suggest that actually this was about putting solutions in there, and this was also about putting our own house in order and not simply blaming every other person for our misfortunes. We actually achieved, as you might expect, things within our own control rather more quickly than we've been able to achieve the things that we depend upon other people for, but nevertheless, we therefore morphed it into a campaign that began in December of 2014, which is the STEP campaign. And the eagle-eyed view will realise that the STEP campaign is actually 4 of the 5 things in the Chem 10 that we needed other people to do. But we've redefined it and re-honed it down to these priorities. And I think these are entirely appropriate, frankly, to most emergency care systems around the world. The only difference is how acute these problems are for you and which ones you would put as first, second or third. So if we talk about staffing has been a real challenge for us in the UK. This chart comes from the NHS benchmarking data. And it in particular shows the fact that though we have a national health service and everybody gets very alarmed at the idea that you'd have a postcode lottery in terms of the services that are delivered to you, I can assure you that we've been living with a rampant postcode lottery in healthcare in the UK for many years. So you don't need to look at all the detail on this chart. Suffice to say that these are the variation ratios in the number of staff you have per 100,000 attendances. So this is all normalised for your attendance rate. And there are some hospitals that have almost 4 times as many consultants for the same number of attendances. Some have 5.5 times as many junior doctors. Some have 24 times as many career doctors. That's probably because we've got so few of them that actually the statistics are slightly skewed. But you can see at ENP level, there's a 14-fold variation in the number of these people that are working in an emergency department. And even if you look at things that aren't actually manpower, things that are resources, look at resus cubicles and patient trolleys, and they also vary by a magnitude of almost 5 times. So there are hospitals dealing with a very, very different set of resources, yet faced with a similar patient load. This is another key data item. I'm sure this is exactly the same or very similar in Ireland. This comes from the Nuffield Foundation, and this looks at the variability in attendances by hour of day and by day of week. And we all know there's a typical pattern, so you get busier around lunchtime and it stays busy until the late evening, and we all know that Saturdays and Sundays are busier, though Mondays are usually actually the very busiest day of the week. What this graph shows, and you won't be surprised about this because this is statistically obvious, is that if you staff your department for 50%, if you staff your department for an average attendance rate, you will be understaffed 50% of the time, and you'll be overstaffed 50% of the time. What it doesn't tell you ordinarily, if you look at that statistic, is the degree to which you are under or overstaffed. This shows 2 standard deviations. So the red line is the mean. You can see 2 standard deviations is the top of that buff grey colour. And this demonstrates that actually substantial portions of the week, most departments are understaffed by 50% of the staff numbers, i.e. you need twice as many staff on duty as you've actually got. And the problem with this, of course, is if it only happens for 1 hour, well, you can catch up. But because of the variation in the pattern, you know that on occasions it will go on for 2, 3, 4 hours. And therefore, you've been understaffed to the tune of 50% of your staff for 4 hours. At this point, you can't catch up, the system tips over, queues form, batching happens, and all the intrinsic inefficiencies that go with that occur. This is a key data item. We've also lost a lot of doctors. This is slightly out of date now. I can tell you that the numbers are slightly larger than this, but the point about this is that we've lost the capacity in the last few years to see the equivalent of 12 district general hospitals. Now, in England, we've got 184 district general hospitals, but we've lost the capacity to see 12 of those because those doctors have gone, they've emigrated. And in their lifetime, they would have seen 25 million patients. Now, last year, we saw 14.6 million patients in English ED departments. So that's a bit like me putting up a notice now in front of every emergency department and saying, I'm terribly sorry, we're shut. And in order to catch up, we won't be opening until the August of 2017. That's what you'd have to do in order to account for that loss of capacity. Obviously, we're not going to do that. Currently, there's 1 EM consultant for every 11,500 ED attendances. So when people accuse me of gilding the lily, I can assure you there is no lily to be gilded here. And our productivity increase has gone up by 7%. If you want to argue it the other way, people are always telling me to work smarter rather than just harder. We already are working smarter to a considerable degree. But we have done some things around this. One of the key things we've done is increase our numbers of people coming into emergency medicine. We've reduced our attrition rate, and we've encouraged people to come in from other disciplines as well, particularly general surgery. And so we now have a fill rate at higher specialist training level of almost 80%. that compares with an average probably of about 90%. So it was going quite well until somebody decided to stand up and try and change the junior doctor contract. And you may be aware of the fact that for only the second time in my life, the junior doctors are on strike in England at the moment. We're also keen to develop other emergency medicine practitioner workforces, and my college is not the Royal College of Emergency Physicians, it is the Royal College of Emergency Medicine, and we welcome other disciplines, particularly from nursing and paramedics, to join our number. We've increased the number of physicians associates, but they're a tiny proportion of the current workforce. But we are starting to credential advanced care practitioners, both paramedics and senior nurses, to work in and alongside us with a qualification that is signed off by my college, your college, our college, and will allow people to have a transferable skill. And there's renewed interest in GPs becoming credentialed. As again, somebody was talking earlier on about portfolio careers and the way in which you can use those to avoid burnout. And this is becoming seen as a very popular option amongst our GP colleagues. So what have we actually managed to achieve? Well, this statement comes from NHS England in August of last year. And they said, whilst it is essential to manage demand on EDs, this should not detract from building capacity to deal with the demand faced rather than the demand that is hoped for. So I'm sure, just like me, you have been told ever since you were a baby that they've got a robust plan next year to reduce attendances and admissions. That's certainly been the mantra of my entire professional life, and every year it has been wrong. So when people say that past experience is no guide to future performance, I think that on some occasions, particularly when it comes to attendances to emergency departments, we can rely on that happening. Tariffs and TERPs. Now, I know you have a very different funding mechanism in Ireland to the one we do in the UK, but this is simply to point out that it isn't just about the money. So we spend less money in England than any other part of the UK. We are well below the UK average. The place we spend the most money is in Northern Ireland. Now, I've been to Northern Ireland. I've been there on a number of occasions. I've had 3 meetings with senior politicians in Northern Ireland. On each occasion, it was a different health minister. It makes it very difficult to have a long-term relationship with people when they keep changing. The other problem, of course, is that their performance, if you look at most of the metrics around patient waits in emergency departments and outcomes, is not better than it is in England, and yet we are spending £2,300 more per head. And the same is true to a lesser extent in Scotland and Wales. So whilst I'm not for one moment suggesting we don't need to invest more of our GDP in acute healthcare than we currently do, it isn't simply about the money, it is what you do with the money. So what do we do with the money? Well, we spend £1.6 billion on healthcare in A&E departments in the UK. Okay, so 186 A&E departments, that's an average of 8.5 million is the annual spend. That pays for every doctor, every nurse, every cup of coffee, every tube of propofol, every monitor, the kit caboodle. And yet, currently, we spend £3 million a week on locum doctors in emergency departments. Not nurses, not bank and agency staff, just locum doctors, just in the emergency departments, £3 million a week. And we've done that for about 4 years now. So every 3 weeks, we could build and fund another emergency department and still save money. So we could build 17 more emergency departments, employ all the staff and all the drugs and all the equipment, and still save money. So this isn't simply about where's the money coming from, we need more money, we need more money. Actually, we can spend less money, we just need to spend it sensibly. Instead of spending it propping up fragile systems that are trying to collapse, we need to invest in them, spend it wisely, and we will rapidly save more money, have better outcomes. So you've heard a lot about exit block, and now we've heard the data from both overseas, both from America and Australia, about how morbidity and mortality is increased in patients who are admitted from busy emergency departments. We now have our own data from Derby published last year. But I think what's very interesting about this is you're more likely to die if you attend an emergency department that is overcrowded, full stop. Even if you get discharged, even if you escape the hellhole that is that overcrowded emergency department, you have a higher mortality than had you attended when it wasn't overcrowded. People talk a lot about 7-day services and the effects of the weekend. If we could stop our emergency departments being overcrowded, we would save somewhere in the region of 1,000 lives a year in England. That's about 40% of the number of people we kill on the roads. There is an awful lot we could do by overcoming exit block. And the reason we have so much block is we've shut a lot of beds. We keep shutting beds. Every time a trust needs to save money, the only way to do it is to close a ward. So they close a ward. They say, we've got a marvellous efficiency plan. We can easily cope without it. We've done it before. And delayed transfers of care have gone up as we find that the social care system simply can't cope with the demographic changes that we've imposed upon it. And we've cut back spending on social care in order to protect spending on healthcare. And really, that's a false economy. That little blip was last, not the Christmas gone, the Christmas before. And because of that, the whole system in England did sort of tip over for a while. And I had to go and speak to the Select Committee in the House of Commons and point out the reason for it. So you would have thought they would know. And so our 4-hour standard performance has gone down, and we're now sitting somewhere lamentably around 85%, but of course that's an average, so there are some poor places which are bumbling along at about 60%. So NHS England, again, say this is a useful measure, a proxy measure for crowding, and so does Monitor. They've been desperate to get rid of the 4-hour target in England for the last 2 years because it makes them accountable for the performance in the departments. I don't think the 4-hour target is a magic bullet, but I know that without it, we would be in a much worse place than we currently are. And so what else have they said? They've said that crowding, and I think this is very important, picks up with what people have said before, happens because of surges in demand and lack of flow through the hospital. Everybody in emergency medicine in this room knows that and lives that on a daily basis. But the second point is, I think, the most interesting. They have finally accepted that crowding affects every measure of quality and safety for patients and staff. And this is why staff burn out. Nobody minds rolling up their sleeves and dealing with a really horrific situation every now and then. But if you know that every day for the next 30 years you're going to turn up and find an overcrowded emergency department, why wouldn't you choose an easier game? Why wouldn't you choose an easier game? The problem I find also is that it's not about the lack of ED staff so much, though that is an issue. If I go to work and they say, oh, we're a registrar and an SHO short, I think, oh, well, that's all right, I just have to work even harder, it'll be fine. If I turn up and there are 14 patients waiting in a corridor for a bed and they've been there for 8 hours, we're doomed. My whole department is not going to work now, and I could be the second Messiah and I'm not going to be able to sort this out because I can't create beds. And so we're delivering ward-based care to patients in ED cubicles who don't want to be there. And we're delivering emergency care to people on ambulance trolleys in corridors who shouldn't be there. And not surprisingly, the patients don't like it. But fortunately for them, most of them will survive and most of them will be out of there within 24 hours. Unfortunately for the staff, they increasingly are not surviving, they're burning out and they're choosing to go and work elsewhere. And so the biggest threat to our healthcare system is losing highly motivated, highly skilled frontline staff. We have made some progress on this, and now this is what monitors say, who are one of the government agencies, and they talk about using my college's advice as to how you manage crowding in emergency departments. And there's been some success with this. They have mandated the use of this toolkit in Scotland, and Scotland this winter has the best 4-hour performance of any country in the UK. Last year it was the worst. They have mandated by the Scottish Government use of the Royal College of Emergency Medicine's crowding toolkit, and this year they have the best. I don't think those two things are unconnected. And primary services. So a lot of people would argue about the money, and I think I've made a good case that actually I think we're good value for money. I think we provide good care and good outcomes at relatively low cost, and speaking for the person who spoke first after lunch, I would echo the fact that we're a strong brand, people like us, and we do a good job. I also think that I have been told many things, and somebody else put up a list of what patients do and don't like. I've had lots of patients say to me, it costs too much money to park here. The coffee machine's rubbish. The waiting room's a tip. I don't like the man in the cubicle next to me. I've never heard anybody say, I had a hell of a job finding this place. We have got these sort of signs all over the country. Millions of pounds worth of signs that have been there for a very long time. Most of the places they point to have been there for a very long time. Even people who only landed at Heathrow last year and speak almost no English find it not difficult to find their local emergency department. So we think we are a good brand. We think we are low cost, high value, and we know that people are going to keep coming to us, again, as the first speaker said. So what we're trying to do in the UK now is move away from the fact that the emergency department is the A&E department. A&E is really anything and everything, and emergency medicine can't be that, because no specialty can be anything and everything. So we're moving to a model where we want A&E hubs. The emergency department is a key component of that hub, but alongside that, we would have community pharmacy, we would have co-located out-of-hours primary care, we would have crisis mental health care teams, and importantly, we'd have in-reach from hospital teams, particularly around the management of the frail elderly, for whom we know that admission to hospital will often precipitate a decompensation in their coping mechanisms rather than an improvement in their outcomes. It's time to forget the idea that an A&E is a department, it's a hub, and at the centre of that hub is the emergency department. And so again, the government, through the Keogh review, have said emergency departments should be fully resourced to practice an advanced model of care where the focus is on safe and effective assessment, treatment and onward care. Nothing about anything and everything, open all hours, turn up with what you like, and let's make the best of a bad job. So our STEP campaign, I think, is something that resonates with most advanced healthcare systems because we all face similar pressures. You could argue that staffing, tariffs and terms are all about the people who work in those departments, and exit block and primary care co-location are much more focused on the patients. But actually, I would disagree. I think that actually, if you've got the staffing and the way we fund acute care right, it's the patients who would benefit more than any other group. But also, if we had no problems with exit block, and we had proper primary services co-location through a hub-type model, the working lives of most of the people who work in our emergency departments would be immeasurably better, would be much easier to recruit and retain the best people. Thank you for your time.
Thanks very much. Thank you, Cliff.